How can a physical therapist help a patient with TMD?
Yeah, that's a really big question. I'll try to give that a good answer. So, when I think about individuals with TMD, I think of two of the biggest problems that they experience are pain and changes in function. And given the consequences of having pain every time somebody opens their mouth, every time they chew or swallow, or even while they sleep, that can be profoundly impactful on their quality of life. So, along with patient education, pharmacological support, and oral appliances, physical therapy is one of those evidence supported, recommended first line conservative treatments for TMD. Um, our best practice standards at this time for TMD recommend a conservative care first before moving to more invasive and non reversible interventions like surgery or changes in occlusion. And physical therapy fits that conservative and reversible approach and certainly has a growing body of evidential support behind it for positive patient outcomes. The national organization of PT is the American Physical Therapy Association, and just by way of definition, a PT is defined by them as a movement expert who improves quality of life through prescribed exercise, hands on care, and patient education. So, PTs are licensed healthcare professionals who help patients manage any acute or chronic problems, and that can include temporomandibular pain. Um, and it also includes pain that can spread beyond the orofacial region to include the head and neck. There's a fairly strong association between jaw disability and neck disability, for instance. So, considering other sources and contributions for TMD symptoms beyond the orofacial pain region is important. I think on a first visit to PT, it might help explain how a physical therapist can help an individual with TMD if I kind of talk through what the process would be. And on a first visit, a patient should expect a very comprehensive initial examination that would include a very detailed history and a comprehensive physical exam. And PT is one of those professions that gets to spend a lot of time with their patients. And this can be really important for these individuals. That can be quite a lengthy process to really dig in and try and figure out all the things that are contributing to the symptoms that they're having. And I really can't stress the importance of that initial care and exam enough, particularly in the orofacial region, where screening for other conditions that are out of scope of physical therapy is very important. So, if that's the case, the role of the PT there is to refer the patient to the right healthcare provider. And that's likely going to be an orofacial pain dentist, a neurologist, or a patient's primary care physician. So, PTs use a biopsychosocial model of care we always have, and that is the recommended model of care for TMD. And this incorporates the patient fully into the treatment plan. So, after the initial evaluation, a patient should expect the PT to explain their findings and any recommendations for care. And the typical sort of interventions that a PT might use include things like manual therapy, therapeutic exercise, neuromuscular reeducation, and a lot of patient education. So occasionally PTs might use electrotherapy or thermal agents to help control pain symptoms, such as laser therapy, ultrasound, heat, electrical stimulation, but that should never be the primary approach to treatment, just an adjunct for pain management. So, defining those terms just a little bit more, manual therapy is really any technique that where the PT uses their hands as a tool to improve joint or muscle function. So, if there's potentially a limitation in the amount of mouth opening a patient can achieve, then mobilizing the joint to improve pain free motion would be an important goal. If there's a lot of muscle pain, for instance, we might use things like manual soft tissue techniques or tools such as trigger point dry needling to help relieve tightness in those trigger points and improve blood flow to promote healing. So, dry needling, particularly, can be a useful adjunct tool in physical therapy because it allows us to reach some of those deeper masticatory muscles that we can't reach otherwise with our hands. Therapeutic exercise is a different approach, and that's usually used in conjunction with manual therapy and neuromuscular reeducation. And that's really helping to promote a normalized jaw motion. So we know that not having enough motion can significantly impact somebody. But what about if they also have too much motion? Either of those cases can be problematic. And we know that prolonged pain itself can lead to maladaptive motor control. And as the brain changes to adapt to that pain through neuroplasticity, we also then get changes in the motor control or movement control of the orofacial area. So, an example of that is a patient who is unable to disassociate jaw movement from, say, lip movement, or jaw motion from neck motion or neck muscle activity. And that's where the role of that neuromuscular reeducation and exercise comes in to better promote more higher quality, normalized motion to help the nervous system regain normal movement control. We kind of have a general saying in physical therapy that motion is lotion. And that's true for all patients with musculoskeletal pain complaints. And we see this through empirical research in other pain conditions and other parts of the body, like low back pain, that the more we can control and normalize movement, we can change the motor control of the region, and that can lead to reduced pain and disability. So that's true in temporomandibular disorder as well. I would say that a really important part of PT is spending time with the patient, educating them about the condition and the control that they have in managing their symptoms, particularly if their symptoms have lasted for a long time. And then, as importantly, teaching them the strategies that they need to prevent or manage future flare ups or symptoms. So that might be by making them aware of abnormal functions of the joint, which we call parafunctions like clenching, tongue thrusting, bracing, etc., and then educating the patient about how they can manage those, maybe through exercise, mindfulness activities, breathing, relaxation, any of those things that will have a goal of empowering the patient to manage, control the symptoms. So even if initial symptoms are resolved, occasional flare-ups we know happen because of the outside forces in the patient's life, whether that be stress or unusual jaw activities or trauma, or any time they're held open for too long with their mouth. So that can promote a joint or muscle pain flare-up, and learning to manage those future flare-ups so that we can get quicker resolution of symptoms can really have a big impact on improving a patient's quality of life, reducing their anxiety, and then reducing healthcare utilization costs down the road. So, Dr. Sani, that was a very long answer to a short question, and I apologize. But in summary, I think PT can do a lot to help patients with TMD.
Thank you very much. That was definitely very insightful, and I would agree that you guys have a lot of tools that can help patients. So my next question to you, Dr. Prodoehl, would be, we can observe that maybe in clinic we have two subset of populations within the temporomandibular disorders. Those patients that might come with TMD, temporomandibular disorders of acute duration, maybe in the last 3 months, 6 months, maybe as a result of an injury. And then we have another patient population that might have more chronic temporomandibular disorders. They've been suffering from TMD for a longer period of time. Are there any differences from a PT standpoint in the way that you approach and manage an acute TMD case in comparison to a more long-lasting chronic TMD?
Oh, wow, absolutely. I would say this sort of defines my patient population, the acute individuals and those with more chronic symptoms, and how we approach those and help the patient manage those should be and is very different. So, individuals with more acute pain or acute episodes of joint locking or limited motion typically have quite high intensity of pain that's debilitating. And in those cases, the first line of treatment is often to just work to reduce the symptoms as quickly as possible, to engage the jaw in normal activity and function so that the body can heal itself and promote natural healing. So I often say to my patients that this part of the body, more than any other joint or set of muscles in the body, is built for motion and function. The joint is moving thousands of times a day. And if it didn't have the ability to remodel and heal, we'd all be in a lot of trouble. So our goal in physical therapy is often to get the body, the brain, the right set of circumstances to do what it wants to do, which is to heal itself and normalize function. The brain doesn't want to continue to be in pain, neither does anybody. So that may mean a short-term changes in behavioral function and a lot of education to allow the joint to heal, but that should quickly progress to introducing normal movement and activities to promote that healing. So in the case of a patient maybe who has problems with locking of the joint acutely, that means they can't either open or close their mouth. They might need a bit more hands-on help through manual therapy techniques to get that mobility back. But again, they have to quickly engage in more exercise activities to promote normal movement control. And then to help address that long-term change in behavior that could address any of the activities that are potentially perpetuating or the onset of that initial pain, then we might need to do a lot more education or even refer the patient to a dentist for oral appliance management. But many instances of acute onset especially first onset TMD pain, can resolve on its own without any specific needed intervention once patients are made aware of what's happening and how they can manage it. Sometimes they just need a bit of education and information from either a PT, a dentist, or a primary care physician to really just normalize the experience and reduce fear. And giving them the right activities and education about what they can do to promote healing and protect the jaw in the short term should help hopefully see some resolution of symptoms in a few weeks. And that if they're not resolving within a few weeks or the symptoms are worsening, I think that's an indication that they need to go in and see somebody, whether that's a physical therapist or an orofacial dentist. And really, we want to get the person back on a healing track as quickly as possible. But for our individuals with chronic symptoms, which unfortunately are the larger proportion of patients that tend to end up in the healthcare system, and by chronic, I mean probably lasting more than 3 months, they typically need a much more structured intervention program of physical therapy that should be multidisciplinary. So in those cases of chronic pain, we tend to see spreading of the pain much beyond the orofacial area, much beyond any original site of injury. And we often see pain developing on the other side or down into the neck or up into the head or even down into the shoulder and arm. And so typically a much more structured, slightly longer plan of care is going to be needed. And that structured nature of the program should also account for the underlying biopsychosocial factors that might be exacerbating the pain condition and accounting for their abnormal neuroplasticity. We see these patients who are centrally sensitized and everything is hurting. And that sort of can lead to that abnormal or promote that more abnormal motor control. And when motor control patterns change, a patient can no longer isolate just the masticatory muscle function. They start to pull in all kinds of other muscles. And when too many muscles are used for too long, that can lead to a secondary kind of myalgic or myofascial pain. So even if the primary condition was joint related for temporomandibular, it can quickly involve the muscles of mastication, the neck muscles, etc. So abnormal movement control doesn't serve normal function, and it actually can lead to the persistence of pain, even when the original injury or insult to the tissue has resolved. And there is a pretty strong neurophysiological and anatomical connection between the trigeminal system, which is the part of the nervous system that supplies sensation to the temporomandibular joint and the muscles of mastication, and the cervical nervous system, or the cervical nerve roots, meaning sometimes that the brain doesn't even know where the pain is coming from anymore. And that can sort of explain some of the spreading of symptoms that we see. And it's also possible that the pain in the face is actually not coming from the temporomandibular region. It might actually be coming from the cervical spine based on that shared sort of innervation and crosstalk between the trigeminal and cervical systems. So, but regardless of where the pain is coming from, the treatment strategy for our individuals with more chronic problems has to be to engage and normalize the movement system. Again, using those manual therapy, neuromuscular reeducation, therapeutic exercise, and a ton of education for these patients to learn how to manage their own symptoms. So I would say for the acute situation, we might only be talking about one or a couple of visits to help normalize function. But for our individuals with the chronic pain, it can be a little bit more dependent on what the individual patient is presenting with. So a colleague of mine, Steve Krause, and I really wanted to help provide some insight into that. So we published a paper in 2019 in the Journal of Craniomandibular and Sleep Practice, where we looked at outcomes and patient satisfaction following a plan of physical therapy care for one specific subtype of TMD, which was disc displacement without reduction with limited opening, to see how these individuals were impacted by physical therapy. So these people have real difficulty opening their mouth, a lot of pain, and we think that some of the pain is because the disc is a little bit displaced, but in general, how are these people going to do with tailored, individualized physical therapy? So this was a small study, but we looked backwards at the records of about 97 patients who were referred to PT from a dental provider, different dental providers, to see what were their typical outcomes, what was their satisfaction, and how long did it take. And so the individualized PT approach was designed for each patient, which is another reason why it's hard to do research in this area, because we actually know that we need to individualize care for the needs of the patient. So it used some combination of therapeutic exercise, neuromuscular reeducation, manual therapy, modalities, electrical, thermal, and a lot of patient education and behavioral modifications. And so in that study, we found that across those patients, the average number of visits was about 5.5. So almost 6 visits, and they led to significant improvements in decreasing pain and improving mouth opening. And the patients themselves rated themselves as satisfied, more satisfied than less satisfied with their outcomes. So that doesn't mean that every patient only takes 6 visits. That's sort of an average. The range in that study was 1 visit to 27 visits, and partly it's going to be due to the acuity of symptoms, this acute versus chronic nature, and what other comorbidities those patients might have. So I often tell my patients who don't have a lot of comorbidities, a more simple TMD, I would really expect you to be feeling significantly better with physical therapy within 3 to 6 visits. And if you're not, then we're going to be taking a closer look and we may need to refer you out. I typically structure my care plans for these chronic patients to see them about once a week to allow those IO behavioral strategies and changes to occur through the patient's home activities. The acute patients might need to be seen a little bit more frequently, 1, 2, or even 3 times a week to get rid of that acute pain. And then we might need to extend that care plan for the individual patients who have a lot more spreading of symptoms beyond the TM area or into the head, neck, etc., or who have a significant other comorbidities. So I would say, again, to circle back, that kind of gives you a general idea of how PT care should be different between acute and chronic. And I would say the take-home message there is it should be individualized to the patient. We certainly have evidence that just giving patients exercises is not as effective as engaging in structured physical therapy. And I think part of that is developing that connection with the patient to empower them that they can't necessarily get just from doing exercises on their own.
Thank you, Dr. Prodoehl, for explaining the differences so well between the acute and chronic TMD patient types. And I think you touched on a very important point about patient education. That's really important when we are managing OFP patients with chronic pain conditions, as we need to approach them differently, but also the role of the orofacial pain specialists and PTs when they work together on these cases is highly important. I think you might have touched on some forms of pain disorders that PTs could help with, but if you could further elaborate on more specific forms of orofacial pain that PTs might work with, which are apart from TMD.
Yeah, so when we think about temporomandibular disorder, that's certainly a large subset of patients with orofacial pain conditions, probably the biggest subset. And physical therapists in general should be well trained or trained in some way to help manage those symptoms. But I think that other orofacial pain conditions require a little bit more advanced training. And we certainly work with individuals who have other disorders such as headache, different forms of neuralgia like trigeminal neuralgia, other symptoms affecting this region like tinnitus, oromandibular dystonia, etc. And PTs work with all of those conditions to, support their other management strategies. But there are plenty of other orofacial pain conditions that are not appropriate for PT. And those are conditions that really need pharmacological support as the primary means of treatment. So that would be things like burning mouth or some other forms of headache. So I think it highlights the need for physical therapists who are working in a direct access environment to be very thorough with their screening to make sure that the patient that they're treating actually fits the scope of PT practice. And if it doesn't, then I think it's incumbent upon us as healthcare professionals to help the patient find and get to the right healthcare profession, in which case, in many cases, that's going to be an orofacial pain dentist or even a specialized neurologist. So I would say for non-TMD related orofacial pain, I think a little bit more advanced training is needed for physical therapists. And then regardless, the physical therapist is going to want to work closely with the rest of the healthcare team.
So you mentioned the training that a physical therapist needs in order to treat orofacial pain conditions in general. So when we are talking specifically about treating TMD, do all physical therapists are qualified to treat TMD? What is the type of training they might need to treat TMD, and what's the type of training they might need to go to the more complex cases in orofacial pain?
Oh, wow, that's a great question. I'm afraid it's not a simple yes or no to do all PTs treat TMD, because much like dentistry, accreditation and training standards have really changed over the past 10 to 15 years. So depending on when a PT graduated from their professional program, the answer is going to vary a little bit. So we can't really have a blanket answer for all physical therapists. So just by way of background, PT is composed of 10 specific specialty areas in addition to general PT practice. And the largest specialty area in PT is orthopedic practice. And TMD falls within as a smaller subspecialty within that larger specialty. But certainly any individual that is working in the orthopedic area should have the tools necessary to start to be effective with these individuals. So currently in the US, TMD content is being covered at the entry level, or should be covered in the entry level in all physical therapy programs through their doctoral training. So in 2018, I, along with some PT colleagues and one of our dental colleagues, did a survey that looked at how TMD content is being covered in the curriculum of PT programs nationally. And we showed that it is covered in almost all programs. It was 98.8%. But there was a significant variation in the amount of hours devoted to TMD content. And that is eerily similar to what we see in the dental education programs as well. There's a wide variation across institutions on one, and I think one of the future goals of our profession needs to be to improve the standardization and training of all PTs. And then within the educational program, this kind of content is often spread out through the curriculum, from anatomy to kinesiology, which is the study of movement, to evaluation, intervention, pharmacology, imaging, etc. And we know that just learning about a condition and putting the pieces together is not really enough sometimes to understand how to work with these patients, particularly when they have more complex forms of TMD. So one of the problems that we see, similar again to dentistry, is that a physical therapist, even if they graduate recently from PT school, they may never have actually had an opportunity to work with a patient. And that will decrease their confidence in working with this area. So sometimes when you ask PTs, have you had this training? And the answer might be yes, if they graduated in the last 10 years. But how confident do you feel? It's not particularly confident. And so there was a study in 2018 where they did a survey of all physical therapists in one state. I think it was Florida. And they had a very, very small return rate. So we have to be a little bit cautious with the interpretation. But it kind of matches what I see in talking to clinicians locally. And that about 70% of the responding physical therapists lacked the confidence to treat TMD. And they specifically pointed to deficiencies in their entry-level preparation. Now, my hope would be that if we repeated that survey in 5 years, we would have a much better outcome because significant changes have happened. So similar to the field of orofacial pain and dentistry, I think the physical therapy profession has a way to go to promoting more confidence and practical experience for new physical therapists so that we can be confident in treating this area and then better serve. This is a chronically underserved population.